Dear colleagues, let me introduce you Malyugin CTR, which is the device designed for scleral fixation. Implantation of CTR is performed with the help of the injector. Here is the case of the patient with traumatic zonular dialysis. CTR is completely retracted inside the injection device. Eyelet of CTR is fixated to the 9-0 polypropylene suture that will be used later for scleral fixation. During injection, the device is easily sliding along the equator of the capsular bag. During surgery, CTR is injected in the direction of the zonular defect. In that case, remaining zonular apparatus will help to stabilize the whole capsular bag. You see how easily the CTR is sliding along the equator of the bag, and now the trailing eyelet will be released to place the device completely inside the capsular bag. CTR is now rotated to place the fixation element in the area of the zonular defect, and the needle is passed through the ciliary sulcus outside of the eye and then fixated to the sclera in the zigzag manner, which does not require any flaps in order to bury the knot of the suture. 4 or 5 bites are usually adequate to achieve good stability and fixation. Fixation element is placed on top of the anterior capsule in order to prevent changing the shape of the capsulorhexis. Hydrodissection is done very gently, followed by in situ phacoemulsification, utilizing combination of horizontal and vertical chops with settings adequate to get a good purchase of the nucleus material. Minimal rotation in that step is required to avoid any significant stress on the zonular apparatus. This is another clinical case with giant zonular dialysis and also hydrodialysis. Again, the CTR is positioned inside the injector tube and fixated to the 9-0 polypropylene with a long curved needle. And while injecting the CTR at the beginning of the procedure, we can actually see how it goes through the transparent injector tube. And actually, you can also see the fixation element of the device sliding along the equator of the capsular bag, which is visible now because of the iris defect. In case the surgeon decide to implant CTR at the very beginning of the procedure, before nucleus content is removed from the capsular bag, he should be aware of cortical material entrapped to the equator of the bag by the CTR, which requires much longer irrigation aspiration time as opposed to the CTR implanted into the empty capsular bag. You see now the other case where femto laser capsulotomy was being done, and this is the patient with Marfan syndrome, and after removing anterior capsule flap, the bag is suspended on MST capsular hooks, and then dry aspiration is performed with the anterior chamber and capsular bag completely filled with dispersive OVD. CTR is now retracted to stabilize it, and we will be using Gore-Tex suture, which is fixated to the eyelet of the device. In the process of injection, you see that the bag is still supported by 2 capsular hooks, and we are gently inserting CTR inside the capsular bag. Gore-Tex suture will be passed through two 25 gauge vitrectomy ports introduced 2.5 millimeters from the limbus. 25 gauge forceps are used to grasp the tip of the suture and retrieve the suture from the eye. This is the other end of that suture, again grasped with the 25 gauge instrument introduced through one of the ports. The suture is tied, the ends are trimmed, and the knot is rotated inside the eye. Now hydrophobic acrylic IOL is inserted into the capsular bag with the help of the injector. Optical elements of that lens are positioned in place with the help of the second instrument. I do believe that Malyugin CTR is very useful in a variety of cases associated with zonular dialysis and generalized weakness. We thank you very much for your kind attention.